Bismillahirrahmanirrahim. Problems on epidemiological studies. Before we start solving the problems, I would like to go with you through a quick review on what you have learned from the epidemiological studies and measures of disease frequency. Morbidity rates. This is how we measure the disease frequency by morbidity rates. Morbidity rates includes incidence rate and prevalence rate. The incidence rate. The incidence rate is the number of persons developing a disease, new cases in a specific time and locality, and by the word developing means they are surely new cases and they weren't suffering from any disease before or the disease under study before. Divided by the population at risk multiplied by 1,000. By the word population at risk, I mean those who are susceptible for the disease. So they must be not vaccinated or they must be not having the disease originally and they are completely susceptible for the occurrence of the disease. We multiply it by a constant. This constant is 1,000, 100,000, million, according to the number of new cases. The attack rate. The attack rate is an incidence rate, but it is measured when, or we call it attack rate instead of incidence rate, when there is a limited period of risk or when this risk is restricted to a special age group. For example, if we say puerperal sepsis, we don't say the incidence of puerperal sepsis in Al-Shadbi Hospital in Alexandria. We call it in this case attack rate because this puerperal sepsis is limited only to the 42 days following delivery. So it is a limited period of risk. Also in case of epidemics, we use the attack rate because the epidemic is never through a year. It is usually within few months. Also in an outbreak, we use the attack rate. Also if for example, a neonatal septicemia, this septicemia is only limited to the first 28 days of life. So we comment on it or we measure for it the attack rate, not the incidence rate. Another difference between the attack rate and the incidence rate that the attack rate must be expressed in percent. Prevalence rate. We have rate or period prevalence rate. Point prevalence rate. This is the number of current cases and it is either old or new, both of them of a specified disease existing at a given point of time, divided by the population on that date at the same point of time multiplied by 1,000 or 1 million according to the number of current cases. Period prevalence is exactly the same like point prevalence, but the period prevalence is the number of existing cases, old and new, of a specified disease during a given period of time and divided by the population during the same period of time multiplied by 1,000. This problem is going to let you understand the difference between the different morbidity rates we just discussed. On the 1st of January 2010, 1,000 females above 40 years of age were screened for diabetes mellitus, and 40 females were proved to be diabetic. During the same year, 20 females developed diabetes. 5 died and 5 migrated out of the country. Calculate the following rates. Point prevalence of diabetes mellitus on the 1st of January 2010. Incidence of diabetes during the year 2010. the point prevalence of diabetes mellitus on the 31st of December 2010, and period prevalence in the same year 2010. So the first one is the point prevalence on the 1st of January. On the 1st of January, when I did the screening, I found 40 females. So the numerator is going to be the 40 females. And at that time, I screened 1,000 females. This is my population. So it is 40 divided by 1,000 multiplied by 1,000. As for the incidence of diabetes during the year 2010, I have only 20 new cases. So my numerator in this incidence rate of diabetes is going to be 20 divided by what is the population who is susceptible at that time. These are those who are not having diabetes. So this will be the 960 coming from the 1,000, and I subtracted the 40 females who already had diabetes. So it is 20 divided by 960 multiplied by 1,000. The point prevalence of diabetes on the 31st of December, this is the number of cases new and old that I will find on the 31st of December. On the 31st of December, I will find the 40, subtracting from it the 5 who died or and the 5 who migrated. So I will be having only 30 females with diabetes, plus those who had the diabetes as new cases during the year. So it is going to be 30 plus 20, 50, divided by the population. What is the population that I'm going to find on December the 31st from my sample? I'm going to find only 990 because 5 died and 5 migrated. As for the period prevalence in the year 2010, this means all cases that I diagnosed in the year 2010 divided by the whole population. So it is going to be 40 plus 20. This is going to give me 60 divided by 1,000. This is my population at the first place. So the period prevalence, because it is 1 year, I will take all the cases that happened during this year and the whole population that I screened in this year, which is the 1,000 females. Types of epidemiological studies. Observational studies, we have either descriptive studies, and the descriptive studies are furtherly subdivided into case study or case report, case series study, correlation study, cross-sectional study or cross-sectional survey. As for the analytical studies, it is subdivided into cohort study and case control study. Both the descriptive and analytic studies, we call them observational because I don't intervene with any kind of intervention. I'm just observing what is going on, and my studied sample, I'm just observing. I'm not intervening by any means, by a treatment or by a vaccine or by even a talk of health education. I didn't do anything. I'm just observing what's going on and collecting my data. In the interventional studies, we intervene by either preventive or curative trials. So preventive, like giving vaccine and placebo; curative, like giving a treatment and a placebo, or making an operation in different ways and comparing the results. Cross-sectional study. Here the population, I take a representative sample and I search for the risk factor and the disease. So this will let me be confronted with 4 groups of the population. My sample is going to be divided unequally into 4 groups. Those who have the disease and have the risk positive, and those who do not have the disease and do not have the risk factor, and those who have the risk factor without the disease, and those who have the no risk factor with the disease present. This is a table that shows the distribution of my findings. So we have, as you see, a 2x2 table, and I have a distribution, alphabetical distribution in the form of a Z shape, A, B, C, D. A, B, C, D in the form of a Z shape. And my two rows, the first row is all those who are exposed to smoking, and in the second row I have those who are not exposed to smoking. As for the columns, I have a yes column. This is for all cases of chronic heart disease, and another column that has those who do not have chronic heart disease. So my four groups are going to be 60 and 20, 40 and 80. If I want to measure the prevalence of disease among cigarette smokers or among exposed, so it is 60 divided by 80 multiplied by 100. If I want to measure the prevalence of chronic heart disease among those who are not smokers, they were not exposed to smoking, this is going to be 40 divided by 120 multiplied by 100. If I want to calculate the prevalence of chronic heart disease, coronary heart disease among the whole sample, which is 200, this is going to be how much? This is going to be 100. This is the all yes for coronary heart disease divided by 200 multiplied by 100. Analytic studies. So from the descriptive, we reviewed the cross-sectional study, and this now the analytic studies. We have the case control studies and the cohort studies. And the cohort studies, we have either prospective cohort or retrospective cohorts. Case control study. This is a study, an observational one, that select subjects for having the disease and comparing them with control, a number of control, those who do not have the disease. They could be double or triple or equal number. They are matched by age and sex or by different confounding factors according to the study. And then we compare the rate of exposure to the risk factor among cases compared to the rate of exposure among controls. And then subsequently, I'm going to measure what we call odds ratio. So let us go through the next slide. This is the tabulation of a case control study. Here I didn't use any of the totals of the rows. I used the total of the columns only. This is a case control study, so my totals in use are going to be the total of the columns. So the rate of exposure among cases is going to be A divided by A plus C. And those who are exposed in controls is going to be B divided by B plus D. To calculate the odds ratio, I multiply AD and divide it by BC. How do we interpret the odds ratio? Odds ratio, if it is more than 1, means that cases are more exposed to the risk factor than controls by X times. 1 time, 2 times, 3 times. If the odds ratio is equal to 1, the exposure has no relationship with the disease. And if the odds ratio is equal to less than 1, it means that the exposure is a protective factor, because the exposure is higher among the controls than it is among the cases. This table shows the distribution of my case control study. Again, it is a coronary heart disease against smoking as a risk factor, and it is a 2-by-2 table, and A, B, C, D are distributed in a Z-shaped manner. And I didn't use any of the totals on the right, which is the total of the rows. I use only the total of the columns to measure the exposure rate. So the exposure rate here is 60 divided by 100. This is a 60%. and the exposure rate among controls is 20 divided by 100 times 100. This is a 20%. And if I want to measure the odds ratio, I'm going to multiply 60 times 80 and divide it by 40 times 20. This will give me an odds ratio of 6. What does this mean? It means that those who have chronic heart disease are liable to be 6 times exposed to smoking than controls. I must also evaluate my study statistically to be sure that this finding is not by chance, and if I repeat this study several times, I'm going to have the same results. Cohort studies. We have prospective cohort and retrospective cohort. Cohort study. This is the flow chart of a cohort study. We have a group of smokers and a group of non-smokers, and then so nobody is sick at that time. Everybody is healthy, but healthy from the disease under study, but they are exposed to smoking or not exposed to smoking. They are followed up for a certain period of time until the occurrence of cases. So occurrence of cases or development of cases means that we can measure the incidence because they are new cases. So I'm going to compare the incidence among those who are exposed of the disease, of course, and the incidence of the disease among those who were not exposed. Here is the tabulation of my finding, and as you see in this cohort study, I used the total of the rows and I didn't use any of the totals for the columns because the incidence rate of the disease among exposed is A divided by A plus B times 100, and the incidence rate among non-exposed is C divided by C plus D multiplied by 100. Here I will compare between the incidence among exposed and the incidence among non-exposed. From cohort study, we measure the relative risk. The relative risk equals the incidence among exposed divided by the incidence among non-exposed. And the attributable risk percent is equal to the incidence among exposed minus the incidence among non-exposed divided by the incidence among exposed and multiplied by 100. How do we interpret the relative risk? The relative risk, if it is more than 1, the exposed to the risk factor are more liable to the disease than those who are not exposed by X times. The relative risk equals 1 means the exposure has no relationship with the disease. And if the relative risk is less than 1, it means that the exposure is a protective factor. In this table, as you see, the incidence of lung cancer among smokers is 20 divided by 200 multiplied by 100. And this means a 10%. On the other hand, the lung cancer among those who are not exposed is 2 divided by 200 multiplied by 100 equals 10%. So if it is, it's 1%. So 10% minus 1%, or this is the attributable risk percent, it means that 90% of cases is due to smoking, but the 90% is due to smoking, and there is another 10% that is going to occur in all cases, and this is due to other risk factors not under study. This means that we stopped smoking. We are going only to stop 90% of lung cancer and not 100% of lung cancer. This means that smoking is incriminated for only 90% of cancer lung cases. The rest is going to occur from other causes. Here, the relative risk is going to be 10 divided by 1 is going to be 10 times. So this means that the relative risk means that the exposure to smoking makes you liable to cancer lung 10 times than those who are not exposed to smoking. Here we start with some problems, and I will give you some time before giving you the answer. You will click for the next slide to note the answer. A city has a population of 250,000. On the 1st of January, 10,000 have disease X, which is incurable. During the year, 1,000 new cases developed and 400 died from this disease. There are 2,500 deaths per year from all causes. The prevalence of this disease on the 1st of January is given by the answer is 10,000 divided by 250,000. This is the population and the number of cases on the 1st of January, a regular prevalence rate. During the year 2015, a rural health center delivered 2,000 females. 100 of the delivered females developed puerperal sepsis. During their puerperium, calculate a suitable morbidity rate. Incidence rate, point prevalence rate, period prevalence rate, none of the above. The answer is none of the above because it is puerperal sepsis, and for puerperal sepsis we do not calculate incidence rate, we calculate the attack rate. There were no new cases of Ebola virus in the United States from January the 1st, 1997 through January the 1st, 1998. Which of the following epidemiologic terms does this statement describe? Incidence, lifetime expectancy, lifetime prevalence, period prevalence, point prevalence. The answer is incidence, because if you imagine that we said the new cases is one case or two cases, so this is an incidence rate because these are new cases and the incidence measures new cases. False or true? The odds ratio is an approximation to the attributable risk. The odds ratio of 1 means that the exposure has no association with the disease. The absolute risk incidence rate can always be estimated from a case control study. The relative risk can be exactly estimated from a case control study. The odds ratio is an approximation to the attributable risk. This is wrong because it is an approximation to the relative risk. The odds ratio of 1 means that the exposure has no association with the disease. This is true. The absolute risk or incidence rate can always be estimated from a case control study. No, it could be estimated from cohort studies only, prospective or retrospective. A relative risk can be exactly estimated from a case control study. No, we have an approximated risk, which is the odds ratio instead in case control studies, or you can say the relative risk can be exactly estimated from cohort studies. An exposure with a relative risk more than 1 should have an attributable risk percent greater than 0. Statistical evaluation of the role of chance may or may not be needed before the interpretation of the study finding. The relative risk less than 1 means that the factor under study is a preventive factor. An exposure with a relative risk more than 1 should have an attributable risk greater than 0. This is true. And statistical evaluation is a must. We cannot only depend on the relative risk or the odds ratio. We have to make some statistical evaluation to find out if it is significant or not significant. The relative risk less than 1 means that the factor under study is a preventive factor. Yes, this is true, because the exposure among those the disease was higher among those who were not exposed. An attributable risk of 10 means that those exposed have a risk 10 times those who are non-exposed. Case control studies are very easy to do and take short time. The odds ratio is the only measure of association that can be measured from case control studies. An attributable risk of 10 means that those exposed have a risk 10 times those who are non-exposed. This is wrong, because this is not the attributable risk, this is the relative risk. Of course, case control studies are easy to do and take short time relatively than cohort studies or interventional studies. The odds ratio is the only measure of association that can be measured from a case control study. This is a true statement. Solve the following problems. Study of the physicians, comparing the occurrence of lung cancer in smokers to that in non-smokers. Is it a cross-sectional study, correlation study, prospective cohort, case control, or a retrospective cohort? This is a prospective study because we started by smokers and non-smokers and we search for the occurrence, the development of new cases of cancer lung. So this is a prospective cohort. Follow-up of a population of adults who were exposed and not exposed during childhood to radiation of the neck to assess risk of thyroid cancer. Cross-sectional study, case control, correlation study, prospective cohort or retrospective cohort. The answer again is prospective cohort, because I started with children who were exposed or adults who were exposed at childhood and those who were not exposed at childhood, and I followed them up until they developed cancer thyroid. So this is a prospective cohort. A study was carried out in country X to find out whether the risk of diarrhea in under 5 children was different between 2 nearby villages. It was suspected that the village B had a higher risk because the community used unprotected wells, while village A used tap water. Village A had a population of 10,000, while village B included 15,000 people. The under 5 populations were 1,000 and 1,500 respectively. The records kept by village health worker responsible for the villages in the previous 4 weeks were checked. Village B had had 100 cases of diarrhea, while village A had had 50 cases. What is this study? A cross-sectional, case control, correlation study, prospective cohort or retrospective cohort? This study starts from the present to the past. So it is a retrospective study because the exposure to the water was the reason. Either tap water or the unprotected well started, and then the diarrhea occurred afterwards. So these are new cases. So this is an incidence, and in this case the incidence is measured in cohort studies, either prospective or retrospective. But because we are searching in the records in the last 4 weeks and we started in the present searching for what happened in the past, is a retrospective cohort. Here, as you see, the temporal relationship is preserved. The exposure to the tap water and to the unprotected well were previous to the occurrence of diarrhea among those who are under 5. So these are new cases. It's an incidence and it is a retrospective cohort study. What are the risks to be calculated from such a study? I think you know how to calculate now the relative risk and the attributable risk. Please, on a piece of paper, sketch the flow chart of this study and tabulate your findings and calculate the relative risk and the attributable risk percent. Macular degeneration is a leading cause of blindness. City's residents aged 43 to 86 years were asked to participate in a recent study to determine the relation between smoking and macular degeneration. At a baseline examination, 1,232 participants were found to be free from macular degeneration and were asked to report their lifetime smoking habits. After 5 years, participants had an examination to determine the development of macular degeneration. Out of 368 never smoked, 26 developed macular degeneration, and out of 864 ever smoked, 79 developed macular degeneration at the end of the study. This study is a cross-sectional or a case control or a correlation study or a prospective cohort or a retrospective cohort. This is a prospective cohort because after 5 years from follow-up, the macular degeneration developed in those who are smokers and another number of macular degeneration developed in those who did not smoke, and we can measure the incidence among smokers and the incidence among non-smokers, and we can calculate the relative risk and attributable risk percent, and you can try this on your own. In Alexandria Main University Hospital, all male patients were interviewed. They were asked about their smoking status to identify smokers. Their blood pressure was measured to detect hypertension. Cross-sectional study, case control, correlation study, prospective cohort or retrospective cohort. This is a cross-sectional study because all the male patients were subdivided into 4 groups: those who are smokers and hypertensive, those who are non-smokers and non-hypertensive, and those who are hypertensive but non-smokers, and those who are smokers but not hypertensive. So this is a cross-sectional study, and we measure the prevalence of hypertension among smokers. Suppose that 200 healthy workers were employed in 2 jobs in the textile industry. One of these jobs, job A, involves a known hazardous exposure and the other, job B, does not. Out of the 100 workers in job A, 20 developed respiratory symptoms by time X. By the same time X, 5 workers in the second job B developed the disease. What kind of study is this? Cross-sectional, case control, correlation study, prospective cohort or retrospective cohort. Again, this is a prospective cohort because I started by 2 exposure in job A and job B, and I waited to the respiratory system symptoms to develop in those who worked in job A and those who worked in job B. During pre-placement examination of 200 employees, 20 persons were hypertensive among 80 smokers, while 6 hypertensive persons were detected among the remainder non-smoker employees. What is the type of this study? Cross-sectional, case control correlation study, retrospective cohort, and prospective or prospective cohort. This is a cross-sectional study because all these new employees, the 200, were divided into 4 groups simultaneously. I was searching for the exposure and the disease at the same time. An epidemiological study was carried and revealed that the development of neural defects in the newborn whose mothers were not receiving folic acid during pregnancy is 50%, while it is 10% among those whose mothers were receiving folic acid rich diet during pregnancy. So this study is a cross-sectional study, case control, correlation, prospective or retrospective. This study is a prospective cohort because this 50% and 10% are incidence of neural tube defects among those whose mothers were taking folic acid compared to those whose mothers did not receive any folic acid. A researcher team followed 1,200 HIV positive patients and a similar group of HIV negative at an outpatient clinic over 3 years to determine the rate of occurrence of cerebral toxoplasmosis. This study is a cross-sectional, case control, correlation, prospective or retrospective study. Again, this is a prospective cohort because it started with those who are exposed to HIV and those who are not exposed to HIV to find the incidence of cerebral toxoplasmosis among both groups to compare them to each other. The association between low birth weight and maternal smoking, the smoking habit of women was determined at the antenatal visit and then subsequently the birth weight was recorded. This is a cross-sectional, case control, correlation study, prospective cohort or retrospective cohort. It is clear here that I started with the exposure, so it is a prospective cohort, and subsequently after the babies were born, I started to record their weight, their birth weight. The study of the effect of parental consanguinity on hereditary diseases in the offspring is best studied by cross-sectional, case control, correlation, prospective or retrospective cohort. The answer is case control because this is a rare condition to find hereditary disease and the parents have consanguinity. So I have to start with those who have the hereditary disease and take a control that is equal in number or double the number and compare the exposure to consanguinity here and there. So this is the way, the easiest way and shortest because this is a rare condition. The other way, I will have to take a group of married couples who are having a family relationship and compare them to those who are not exposed to this family relationship and follow them until they get pregnant and they have delivered their babies, maybe first baby or second baby, until I find this hereditary disease. So it is nonsense to go through prospective cohort in such case. An investigator selected 100 women with a confirmed diagnosis of rheumatoid arthritis and 200 women free from rheumatoid arthritis, but undergoing treatment at the same medical facility for other musculoskeletal condition. All subjects were reviewed for evidence of oral contraceptive use. Cross-sectional study or case control, correlation study, prospective or retrospective cohort. It is clear here that it is a case control study, as I started by cases with rheumatoid arthritis and a double number of women who are free from rheumatoid arthritis. So this is a case control study. An investigator suspects that acetaminophen use during the first trimester of pregnancy can cause neural tube defects. She estimates the risk of neural tube defects in the general population is 1 to 1,000. Which of the following is the best designed to investigate the hypothesis? Again, the best way is to choose the case control and take children with neural tube defects and other group who do not have neural tube defects and ask about the maternal intake during pregnancy of acetaminophen. Officials at a large community hospital report an increased incidence of acute lymphocytic leukemia among children aged 5 to 12. They point out that some households in the community are exposed to chemical waste from a nearby factory. They believe that chemical waste causes leukemia. If a study is designed to evaluate the hospital officials' claim, which of the following subjects are most likely to comprise the control group? So whom you are going to choose as a control group? Children exposed to the chemical waste who do not suffer from acute lymphocytic leukemia, or children not exposed to the chemical waste who do not suffer from acute lymphocytic leukemia, or children from the hospital's outpatient clinic who do not suffer from acute lymphocytic leukemia, children not exposed to chemical waste who suffer from acute lymphocytic leukemia, children who suffered from acute lymphocytic leukemia but got cured. Of course, I will choose the children from the hospital's outpatient clinic who do not suffer from acute lymphocytic leukemia and have the probability of being exposed or not exposed. But if I find the exposure is very low in them and very high in the other group who had the acute lymphocytic leukemia, this means that the exposure is higher in cases than in controls, and here the odds ratio is definitely going to be more than 1, and I will have an association between both of them. "500 women aged 40 to 54 who present for routine checkups are asked about their meat consumption. 20% of women turn out to be vegetarian. During the following 5 years, 5 vegetarians and 43 non-vegetarians developed colorectal cancer. Which of the following best describes the study design?" This is a cohort study, as we have a follow-up to those who are exposed or not exposed to the consumption of meat. A group of patients with lung cancer is matched to a group of patients without lung cancer. Their smoking habits over the course of their lives are compared. On the basis of this information, researchers compute the odds of smoking among patients with lung cancer compared to the odds of smoking among those without lung cancer. This is an example of a case control, cohort, cross-sectional, longitudinal, randomized controlled study. This is a case control study. In a study, a group of people are exposed to an environmental toxin but are not treated. Instead, they are observed over time on a standard set of measures to ascertain the potential effects of the toxin. This type of study design is called clinical trial, double-blind, longitudinal, prospective cohort, or retrospective cohort. This is a longitudinal study because I chose a group of people who are exposed to an environmental toxin and I didn't compare them to any comparative group, so it is only follow-up of those who are exposed over a period of time. This is called longitudinal study. A new drug with in vivo activity against HIV is tested on a population of patients with Western blot confirmed HIV infections. Out of the 200 individuals in the patient population, 100 are chosen by lottery to receive the drug. The drug, which is tasteless, is administered in a cup of orange juice. The other patients receive pure orange juice. Neither the nurses, doctors, nor the patients know which patients received the drug. At the end of the study period, the number of the CD4 positive T cells is determined for all of the subjects. This is an example of a case control study, case report, cohort study, cross-sectional study, double-blind randomized clinical trial. Of course, this is a double-blind randomized clinical trial where doctors and nurses are blinded and patients too. Based on the information in the 2x2 table below, which of the following expressions represents the prevalence of the disease? Of course, those who have the disease is Y plus X. So the answer is Y plus X divided by the grand total, which is X, Y, Z, and W. So W and X are all the cases divided by the grand total, which is W plus X plus Y plus Z. In a survey of 10,000 IV drug users in Town A, 1,000 turned out to be infected with hepatitis C. During 1 year of follow-up, 100 patients with hepatitis C infection died. Also during follow-up, 100 IV drug users acquired hepatitis C. Which of the following is the best estimate of the annual incidence of hepatitis C infection in IV drug users in Town A? So the annual incidence is 100 divided by 9,000 because of I subtracted the 1,000 who were infected. I reduced it from the 10,000 population as they are not at risk. An observational study in diabetes assesses the role of an increased plasma fibrinogen level on the risk of cardiac events. 130 diabetic patients are followed for 5 years to assess the development of acute coronary syndrome. In the group of 60 patients with a normal baseline plasma fibrinogen level, 20 developed acute coronary syndrome and 40 did not. In the group of 70 patients with a high baseline plasma fibrinogen level, 40 developed acute coronary syndrome and 30 did not. Which of the following is the best estimate of relative risk in patients with a high baseline plasma fibrinogen level compared to patients with a normal baseline plasma fibrinogen level? So here the relative risk is going to be 40 divided by 70 divided and the incidence 20 over 60. So here this is going to be the relative risk. A study is performed in which mothers of babies born with neural tube defects are questioned about their acetaminophen consumption during the first trimester of pregnancy. At the same time, mothers of babies born without neural tube defect are also questioned about their consumption of acetaminophen during the first trimester. Which of the following measures of association is most likely to be reported by the investigator? Prevalence, median survival, relative risk, odds ratio, hazard ratio. As it is a case control study, the odds ratio is the best measure of association in this study. At a specific hospital, patients diagnosed with pancreatic carcinoma are asked about their current smoking status. At the same time, hospital patients without pancreatic carcinoma are also asked about their current smoking status. The following table is constructed. What is the odds ratio that a patient diagnosed with pancreatic cancer is a current smoker compared to a patient without pancreatic cancer? The choices are in front of you. I will just give you a few seconds to decide. The odds ratio is going to be 50 over 40 divided by 60 divided by 80, and this is the same like 50 times 80 divided by 40 times 60. Any systematic error in the design, conduct, or analysis of a study that results in a mistaken estimate of an exposure's effect on the risk of disease is called confounding bias, interaction stratification. This is bias, of course. The purpose of a double-blind or a double-masked study is to achieve comparability of treated and untreated subjects, reduce the effects of sampling variation, avoid observer and subject bias, avoid observer bias and sampling variation, and it is already solved in front of you, avoid observer and subject bias. Randomization of a study subjects in a clinical trial is most helpful for controlling for which of the following: placebo effect, recall bias, non-compliance, effect modification, or confounding. Of course, randomization controls the effect of confounding. A case control study is conducted to assess the association between alcohol consumption and lung cancer. 100 patients with lung cancer and 100 controls are asked about their past alcohol consumption. According to the study results, alcohol consumption is strongly associated with lung cancer. Odds ratio equals 2.5. The researchers then divided the study subjects into two groups, smokers and non-smokers. Subsequent statistical analysis does not reveal any association between alcohol consumption and lung cancer within either groups. The scenario described is an example of which of the following: observational bias, observer bias, confounding, placebo effect, non-response bias, recall bias. This is an example of a confounding factor, which is alcohol, and the interpretation of the study, it is smoking that caused the cancer lung and not the alcohol. A study is conducted to assess the relationship between race and end-stage renal disease. Two groups of pathologists independently study specimens from 1,000 kidney biopsies. The first group of pathologists is aware of the race of the patient from whom the biopsy came, while the second group is blinded as to the patient's race. The first group reports hypertensive nephropathy much more frequently for Black patients than the second group. Which of the following types of bias is most likely present in this study? Confounding, non-response bias, recall bias, referral bias, observer bias. The answer is observer bias. A study is conducted to assess the relationship between the use of an over-the-counter pain reliever during pregnancy and the development of neural tube defects in offspring. Mothers whose children have neural tube defects and age-matched controls with unaffected children are interviewed using a standard questionnaire. The study shows that use of the pain reliever during pregnancy increases the risk of neural tube defects, even after adjusting for race, other medications, family history or of congenital abnormalities, and serum folate level. Odds ratio equals 1.3 and p equals 0.03. Which of the following biases is of major concern when interpreting the study results? Of course, as it is a case control study, and this is history during pregnancy of mothers who have children, so I am subjected to recall bias. Thank you very much. I enjoyed very much the presentation. Thank you.